So we are broadcasting now. I want to welcome everybody as they are beginning to come in. I think we have for this presentation, I'm sure it's a lot of people that are being tuned into this. And I also want to let everybody know this is going to be recorded and available on our on the Hoover website for a while.
Tal, where are you broadcasting from? Is that
I'm broadcasting from my third bedroom, which is my office. And as you can see, it's a bit of a bomb site. My ski gear is in all these black boxes, which hasn't been used for a few years now. And I've got a bass guitar behind me. That's my Music Man 5-string. And I've got a little guitar amp and an electronic keyboard, filing cabinets, a crossbow, lots of books, all sorts of stuff.
Wonderful. We'll have to compare notes on guitars at some point.
Oh, well, I'm a very keen bass player, I am, Duke, very keen.
Excellent, excellent.
Unlike Rachmaninoff, I put my spidery fingers to work on a long scale keyboard rather than a long scale fretboard rather than a keyboard. Bizarrely, I suspect the joint flexibility, the additional joint flexibility actually helps in some situations.
Yeah. So we had 254 people who've added this to their agenda. And I am going to start sharing my slides, as Bruno said. Bruno, can you see the videos now? I'm not on my side. I'm not seeing the videos.
I cannot see, I can't see your screen at this moment.
Oh, I'm not, maybe I'm not.
See if you can just share the window for PowerPoint.
Yep. Hold on 1 second, that's why.
No problem.
Computer sound on. Share. There we go.
All right, looks good.
Okay. We have 24 people on at this point. If everybody wants to let us know where you're located, you can put that in the chat box. And we'll just wait to the top of the hour to get started. Okay, we have 32 people on right now. And as since it will be recorded, anyone that can't watch it live will be able to view it at a later time. Just a few more minutes and we'll begin. Bruno, when I play the recording, just make sure you give me a thumbs up on sound.
Sounds good.
It should be on, so just want to make sure.
Will do.
Mhm.
Bruno, where are you located?
I'm in New York, Queens, New York.
Ah,
Yeah.
We have a number of people that live close by the foundation, but we have a lot of people that are in different parts of the country now.
mhm.
But we're all working virtually for the last several months, so. And surgeries have been picked up again in Massachusetts. Things are okay.
Yes, not quite to the pre-COVID levels, but maybe about 80%, 90% of the pre-COVID.
Mhm. How's things in England, Tal?
Very slow still.
Really?
Yeah, very slow. Interestingly, the Czech Republic didn't miss a beat. They've just carried on with elective surgery right the way through.
Wow.
Australia's now back online. New Zealand's back online.
Mhm.
Holland's picking up. The UK's pretty slow.
Mhm.
I think we've done a couple in the UK, maybe 3 in the last sort of 2 months, 3 months. But the Czech Republic just went steaming ahead.
Wow.
They do like it over there, though, I must admit.
Mhm. All righty, so it is 12 o'clock. We have 57 participants on the webinar at this point, so I think we should just get started. So I just want to introduce myself. I am Josephine Green. I'm the Chief Science Officer for the Marfan Foundation. I'd like you to also introduce my colleague, Bruno De Salva, who is the project manager.
Hello.
So we want to welcome everybody to the third and final week of the International E3 Summit, Educating, Empowering, and Enriching Our Community, brought to you by the Marfan Foundation and its divisions, the Loeys-Dietz Syndrome Foundation, the VEDS Movement, and our partners at VASCERN. We want to thank you all for making this summit truly historic. It is by far the Foundation's largest event with nearly 2,800 registrants from more than 72 countries. And we hope that you all had an opportunity to connect with people from all over the world in the app and that you can maintain these connections after the summit. You, as you surely know, you are not alone in this journey. We are all here for you. So we want to be very, very thankful to our presenting sponsors, and that's Brigham and Women's Hospital and the American Communication Construction Company. So before we start the presentation, I just want you to all know that the International E3 Summit is a forum to provide an open discussion of issues related to genetic, aortic, and vascular conditions. The opinions stated in each of the talks are those of the Marfan speakers, and not necessarily those of the Marfan Foundation or VASCERN. So if questions arise or clarifications are needed about difference in opinions and session speakers, please contact us at marfan.org/E3ask. we'll be happy to provide any kind of explanation, clarification. Just be patient for answers because we are getting a lot of questions into that email. So today I just want to begin by introducing our speakers. As I said, I'm Josephine Grima, the Chief Science Officer, and I'd like to introduce my co-moderator, Dr. Duke Cameron, who is a cardiac surgeon at Massachusetts General Hospital and has been on our PAB, our Professional Advisory Board, for many years. And Duke, I would appreciate if you can introduce our main speaker for today.
Very good. Thank you, Josephine. First of all, I want to welcome everybody to the E3 Summit. It's been a fantastic program, and I'm proud to be included as part of it. It's an even greater pleasure, though, to introduce our speaker for this session, Tal Golesworthy. Tal is an engineer from England who is the architect of the PEARS approach, this new approach, an extremely innovative and promising technique of stabilizing aortic aneurysms, which, as you'll hear in the next half hour, may offer some tremendous advantages over conventional surgery. Tal is remarkable in being an engineer and a patient, but really coming up with this very, very creative approach. He is also a great collaborator and has worked with other engineers and surgeons to develop a very comprehensive approach to aortic aneurysms. He is also a very engaging and colorful speaker, and if you've not heard Tal speak before, you are in for a treat in this next 30 minutes. So at this point, and I don't want to tell you more about him because he's going to reveal a lot in his talk, which I think you'll find just fascinating. So without further delay, let me introduce Tal Golesworthy, who will tell you about the PEARS procedure. Tal.
Tal, if you just want to say a few words to everybody before we get started, that would be great too.
What do I say after an introduction like that? I think everything is. I think the presentation will tell people pretty much everything they need to know.
Mm-hmm.
But and I would like us to focus really on the presentation, its content, and the clinical outcomes,
Mm-hmm.
rather than on me. I'm not someone who likes having the spotlight shone on them, really. So how about we run the presentation, Josephine?
Okay, I have one or two more slides and then we'll run the presentation.
Great.
Hold
Thank
on
you.
one second. So we also want to let everybody know that we would appreciate their feedback after the session. Within your Hoover app, you can just click on the rate button and answer three short survey questions. And we'll get ready for the presentation. Everybody can turn off their videos and mute themselves.
Everyone, my name is Tal Golesworthy. My academic training is chemistry and electronics. My professional training is as a research and development engineer in industrial combustion and air pollution control. So I spent a lot of time working in developing new technologies to stop nasty things going up chimneys. You can see I'm a chartered engineer, and you can also see from the bottom end of my screen a little logo for Extent Limited. I'm actually the technical director of Extent Limited as well, which I'll explain a little later, and that's by way of an admission of a potential conflict of interest. I also have Marfan syndrome, as I'm guessing many of you guys do, I had Marfan since I was about 6. My grandfather had it, my father had it. I had the typical sublux lenses associated with Marfan and the long, thin bones. And in 1992, in my 30s, my dad, who was retired and sort of needed something to do, dragged me along to a genetic study at St. George's Hospital in London, where my aortic root diameter was measured. This is a graph of my aortic root data over the years. The green lines define what's considered by most to be a normal aortic root size, about 3.2 to 3.6 centimeters. 5 centimeters was at that time the point in the UK where surgical intervention was pretty generally recommended. And at my first measurement, I found to my horror that I was at 4.4 centimeters. I'm sure all of you who've been through this will recognize those words implicitly. You can see that for me, this started a sort of an annual transthoracic echo measurement regime over the years. And even though I did my best to deny it was getting bigger, it was getting bigger. I was talked through on my first anniversary, actually, in 1993, I was talked through a total root replacement operation, the Ventricle operation. And I can remember being a little bit uncomfortable at the thought of that. But I didn't know anything about it. I just pretended nothing was happening as the years rolled by. And then I got to 2000, and my aorta had got to the point where the surgeons were going to want to get involved. So I was forced into doing something about it. So in 2000, sorry that my mouse pointer keeps going to sleep. In 2000, I attended the Marfan Association Information Day at St. George's Hospital, where a certain cardiothoracic surgeon, Professor Tom Treasure, did a presentation on aortic root surgery for dilated aortas, at the end of which he asked for any questions and answers. So I sort of said, well, Professor Treasure, I said, why aren't we scanning these aortas, CAD modeling them, making models of the aortas, and then making a perfectly fitting external support? Because, you know, my Marfan aortic wall is a bit weak in tension. It's not very, it's fine in compression and bend. It's only the tensile loads that need to be managed. So Tom and I together started this project. Tom got John Pepper involved, the surgeon at the Royal Brompton. I went along and hired Imperial College, and I got a few other people lined up. We actually approached a big cardiac charity in the UK to fund it, and they refused to fund it. So in the end, I had to start a company, do all the investor presentations and raise all the money myself to make it all happen, which is why I end up as the technical director of Extent Limited. So those of you who are uncharitable will say I'm just somebody making money out of this. Those of you who are sensible will realize that the only way I could raise the money was by starting a company. So the feasibility project was run by me for 4 years, and in 2004, I had the first PEARS operation, and I only measure and plot variables on graphs. I don't plot constants, and this number hasn't changed since. So the graph ends in 2004. Okay, so the part of the arterial system we're concerned with is the aortic root. This is a side view of me. That's some part of my chest and sternum. This will be some part of my spine. And you can see in the little red box here, you can see the aortic root and ascending aorta. This is the left ventricle forcing blood up into the aortic valve. And you can there see 3 leaflets of the aortic valve. And then this is the aortic valve structure here. So we have an aortoventricular junction at the bottom, a sinotubular junction at the top, and then the ascending aorta going up towards the brachiocephalic artery and the aortic arch, and then down the descending aorta. The reason this bit is the piece that suffers mostly is because it's the largest diameter piece of the system typically. But this is really just to give you an understanding of what it is that we're actually looking at. It's actually this very, very early part of the aorta. I know none of us like mathematics, but this is actually fairly straightforward and quite important. As I said before, it's the tensile loads in the aortic wall which are a problem for a fibrillin deficient aorta like ours. And the load in the wall is actually very easily measured. It's the pressure, P on the top, and that's essentially your blood pressure. The diameter, As I said, it's the largest diameter where the load is biggest, which is your aortic root diameter, and then 2 times the wall thickness. So that's the aortic wall thickness down there, the little T. What's interesting is as D gets bigger as your aorta dilates, T pretty often gets smaller. The aortic wall thins as it stretches. So as D gets bigger, that makes the tensile load increase in the wall. And at the same time, T gets smaller, which also makes the load in the wall increase. So you've got 2 factors which are both working against you. And this is why aortic dilation is relatively dangerous and needs to be treated seriously and looked after seriously. So, I mean, this is my project aim. As I say, the fibrillin deficient aortic wall in Marfan is okay in managing the compressive loads on it. It's okay in managing the bending loads, but it's not okay in managing the tensile loads. So what I want to do is to make an external support. Some people had tried what I call ad hoc wrapping in the past, notably Francis Robicek and Mano Thubricar, and they'd had some serious problems, not least of which was the difficult shape. I became aware of those as I did the research at the start of this project, and I therefore was even more inclined towards a properly engineered, made to measure, custom device. So this isn't just a bit of material you cut out with a pair of scissors and hope it fits. This is an absolutely specific device made for each patient. My assumption, which was proved to be correct, was that if we could do an external support for an aorta with a properly fitting device, we could then conserve, we could retain all of the patient's natural tissues, all of the natural structures, and that would mean we could avoid the need for prosthetic valves in particular, which would then mean I wouldn't need any anticoagulation therapy. It was actually the fear of anticoagulation therapy that really drove me to do this. I'm sure I shall say some more words on that a little later. So how do we make one of these things then? Well, we invite the patient to go to their local hospital and have a relatively standard CT scan. I'm sure many of you have had CT scans so far. We have a very straightforward CT scanning protocol we can email out to hospitals. I would guess we've had patients scanned in probably 50 hospitals around the world. And essentially we get a really nice high quality image set from the top of the left ventricle, which I showed you in that MR earlier, up to the top of the aortic arch. So we've got the whole of the aortic valve and the ascending aorta in view in our image set. They need to put a little bit of contrast agent in you, which isn't really a big deal. But that's the basic data which we use to start making the device. When we have got the CT data from each patient, we process it and feed it into a computer-aided design program, which our CAD engineer, Warren, who still works with us actually, wrote and then creates all the CAD models for all the patients. This is a transaxial, a horizontal view through the aortic valve. So you can see that there is 1 sinus, 2 sinuses, 3 sinuses of the aortic valve. And you can see the gray CT. And on top of that, you can see superimposed the red dotted lines, which are the 2 lines, the inside and outside of the model which we make of your aorta. The gap between these 2 lines, incidentally, is 4 millimeters. So you can see that the quality of fit of our outside line to the patient's anatomy is very, very good. A typical CT image is only plus or minus 1 millimeter at best. So if you see anything that's within a millimeter, it means it's pretty much spot on. This is a side view of the aorta, again with the computer-aided model overlaid onto it. And you can see that the quality of fit is really very good. So there's 1 sinus of the aortic valve. There's another sinus. This is the aortoventricular junction, which is where the bottom of the implant goes. And our implant goes all the way up here. And in fact, the top end is typically looped around the brachiocephalic artery. You'll see down here that we have a section of the former which sits below the implant. This has the patient name, the patient date of birth, and the patient hospital ID number in it. The implants are supplied to the surgeon on their formers right to the operating room, and the surgeon can check on this former that he is putting the right implant in the right patient. These are custom devices. It would be disaster to put the right implant in the wrong patient. So having all the patient data available to the surgeon in the operating room is a safety issue which we consider very important. This is just a quick review of what we're doing. Essentially all we're doing with some very, very clever scanning in CAD is taking a whole series of measurements out of this aorta and turning them into one of these. As I say, the CAD has evolved slightly, but essentially we got the routine right first time. And so we get very, very nice high quality CAD of aortas, and we've probably modeled around 400 aortas now, and we're getting very, very nice results with it. So the CAD model is this, and as you can see, it is not a two-dimensional representation on a piece of paper or on a computer screen. It's actually a three-dimensional structure living in computer memory. This is actually the CAD model of my Marfan aorta, my dilated aorta. I was talking earlier about trying to wrap one of these aortas ad hoc. You can see down here, we've got the aortic valve. There's one lobe, there's another lobe, there's another lobe. It's a trilobal section. Then that turns into a circular section. Then that tapers and bends away to the arch. So it's a complicated shape. So you can't just cut some material and try and make it fit as the ad hoc wrapping people have found. Another couple of important features on the CAD model are the coronaries. There's the left coronary ostium. There's the right coronary ostium. The coronaries are the small arteries that come out of the aorta and feed blood to the muscle of the heart. And they are probably the most important blood vessels in your body, because without them, your heart doesn't work. It's very, very important to accurately locate these so that the surgeon can make an accommodation for them in the finished implant. It's also interesting to note that as an aorta increases in diameter, it stretches in length. And if you look at my left coronary, which is about to come round here, that's about halfway up the sinus. But if you look at my right coronary, it's drifted right up the sinus. Originally, those coronaries would probably have been about halfway up the sinus. Now that right coronary, you can see, is drifted up probably a centimeter. So there's axial dilation as well as diametral dilation as the fibrillin deficient vasculature, the aorta, changes shape under the influence of the blood pressure. Once we've got the CAD model, we then turn that into a physical model. Now we use an additive manufacturing or a rapid prototyping technique. We don't use 3D printing, though that is a generic name that's used for these things. We actually use SLS. But you can see we have here an absolute rigid physical model. This is the hard plastic model with the 4-inch walls. You can see one of the aortic sinuses sticking out there, another one sticking out there. You can see the right coronary ostium that's been drilled through. So this is what we form the implant on, and this is what gives the shape of your aorta to the implant, because each implant is totally different. A number of cardiologists have said to me, "Can't you just make one size to fit them all?" And then I show him this picture, and as you can see, there's a coronary that's way up the sinuses. There's a coronary that's quite high. Every patient is different. We're all different. Even if we're healthy, we will all have different aortas. So you've got different sizes, different shapes, different bends. You've got coronaries in different positions. We even did a pair of identical twin teenager brothers. I know Hayden and Isaac very well. I still can't tell them apart. They are absolute. They're just totally identical. They live in the same house. They go to the same school. They live the same sorts of lives. When I checked their CAD models, as I check all the CAD models, I was amazed to see they had completely different aortas. So clearly our understanding of aortic dilation is imperfect, and clearly we are all different, which is why a process which involves a completely customized device for each patient is absolutely critical to make an external support work. Okay, once we've got the former produced, we then produce the implant on the former, and this is an example you can see. So this is the hem, the proximal hem at the bottom, which runs around the aortoventricular junction. When this is sutured closed by the surgeon, it holds the AVJ exactly where it is, and in fact the entire implant holds everything exactly where it is. There will be a coronary ostium, which we can't see there. The surgeon will be able to see it as he handles this, and he will make a cut through the implant from that hem out to this coronary and cut a little hole, an asterisk hole, and he will cut another one round the back from where we can't see to the right coronary. He will then open this axial seam, which runs all the way up the device, open the device off the former, and then implant the device. So as he implants the device, he closes this this seam at the bottom. Sometimes he sutures it into the heart, other times he doesn't. Then he essentially just closes up the various seams. So he'll close up this seam, he'll close up the lateral cut he's made to that coronary, close up the other one, close up this seam, and then the top end, typically he will loop around the brachiocephalic artery. So when he puts this device in, he doesn't have to suture into the weakened tissues of the aorta as he would have to were he using a root replacement graft. This actually has prompted one of our surgeons to say, given how fragile Loeys-Dietz tissues are, this is an absolutely perfect device to provide the best solution for Loeys-Dietz. When we supply the implants to the surgeon, we always supply two, and in case he loses one, if one becomes unusable for any reason, it gets damaged, it gets adulterated, it gets dirty, if it can't be used, he needs a fallback position. So we supply him with two, and we typically scale them differently on diameter. So there'd be 100% one, and there'd be a 95% one, or a 90. For many of us whose sinuses have dilated, as the sinuses have dilated, so the aortic valve leaflets have moved apart. And for many of us, there will be a little bit of aortic regurgitation, or perhaps a lot. What the surgeon can do is he can use the 95% device, or maybe even the 90% device, if that's what we've supplied him with. And when it's installed, it brings the diameter of the entire aorta down so that large sinuses are now slightly smaller. Those leaflets have been brought together, so aortic regurgitation can be reduced or, in fact, completely eradicated. Now, we didn't anticipate this being possible when we started, but we do know that in a significant number of our patients, we have eradicated aortic regurgitation. This means that the patient, as well as having his aorta secured, has now got a normally functioning aortic valve, which is really great news for the patient, really great news. Okay, as far as the surgical implantation goes, this is a tricky operation. Those who think PEARS is easy are absolutely wrong. My guess is, and I don't know, but my guess is only the top 10% of cardiac surgeons are going to be good enough to do this, because very, very frequently, and that would be in about 80% of our cases, PEARS surgery is done without cardiopulmonary bypass. You know, if you need cardiopulmonary bypass, if you're having some work done inside your heart, then you know it's a lifesaver. If you can avoid it, it's probably best avoided because of the biochemical stress that the CPB priming fluid gives your body. We don't need to use hypothermia, and we don't need to use any cardiac arrest. So in that sense, this surgery is relatively non-invasive, but technically it is very demanding. To do that dissection right down to the aortoventricular junction on a beating heart without injuring the coronary arteries requires an awful lot of patience and care. Just incidentally, this is a picture I took in Prague a couple of years back. This is John Pepper, my great friend and fantastic guy. This is John Pepper, who did the first 20 PEARS operations, and he's actually proctoring Peter Kacher, who's the head of surgery at FMKV in Prague. So this was Peter's first PEARS case. The case actually was a lady with Loeys-Dietz in her 40s with three children. She was home, I think, in about 5 days, feeling great. She said she rang up Peter Kacher afterwards and said, "This is great. Can my other two children have PEARS, please? Because it's clearly, you know, a much easier operation to go through than root replacement." Anyway, that's a rundown of the surgery. A heads up for those of you who don't like surgical video, close your eyes or turn away now. This is me, in fact, on the 24th of May. My head is at the bottom of the image, so my feet at the top. This is my ascending aorta, that's my ventricle, and this is the little fat pad around my right coronary artery. So you can see that the device is a very snug fit on the aorta. You can see the pores in it through which pericardial fluid and various other things can travel. We know, for various reasons, that it becomes completely incorporated into the outer layer, the adventitia of the aorta, to form a new fabric reinforced soft tissue composite layer, which is even stronger than the implant itself. So we're very confident that once one of these goes in place, nothing is going to change. Okay, does it work? Is it efficacious? Is it safe? Does it work? This is a sagittal, a side view of me. This is my breastbone without any sternal wires. This is my spine. This is my breastbone with sternal wires. Again, this is the part we're interested in. We're going from the aortoventricular junction up round the aortic valve past the sinotubular junction, up the ascending aorta to the brachiocephalic. So given the limitations of getting the patient in exactly the same position in the scanner and getting the scanning plane exactly right, I would argue that that morphology, that shape is identical to that one. I've actually been updating this photo on my presentations over the years, and they just never changed. I have a scan every year at the Brompton. I go and get in the MR scanner, and I waste about a couple of £1,000 of NHS money for them to scan me, and then they send me a report and says, oh, look, everything's exactly the same as it was the year before. Sorry, last year and the year before that and the year before that. So nothing changes. We are stabilizing the aorta. We are seeing no dilation. We are seeing no dissection. My aortic valve remains completely competent. And isn't that great? Isn't that great? Isn't that what we set out to do? The other interesting thing is I don't need to take any drugs as regards my my PEARS implant. Of course, the rest of my aorta, which is the same for those of us with root replacements, is unprotected, and maybe some beta blockers or maybe some angiotensin receptor blockers or other such drugs might help in protecting that. But as far as my ascending aorta goes, it's completely stable. So how are we getting on in respect of numbers? Well, I put this together in July and August, in fact. So we're now in September, or we will be when you listen to this. We've done over 349 patients. We've got over 1,000 patient years between us. No dilations, no dissections, none of that business. Not enough clinical evidence to convince all physicians. A little bit sad, but there you are. Interestingly, our youngest patient was actually a 3-year-old with an adult-sized aorta. She was fixed in Brisbane, and the only part of the implant which the surgeons put in was her AVJ to her STJ just to stop her aortic valve growing anymore because it's already at adult size. They left her aorta alone, so her aorta can carry on growing, and they'll carry on monitoring, and hopefully it'll stop when it gets to a sensible size. Our oldest patient was a 75-year-old, but I note with some interest that our largest patient was actually a bicuspid aortic valve patient, not a Marfan patient. He was, I think, 68 when he had his operation. 2 hours off pump. He had a 6-centimeter diameter ascending aorta. He had a 2-hour operation off pump, and he's right as rain. He even came all the way from New Zealand to have a pint with us the other year, which is rather nice. As you can see, the bulk of the patients are in the sort of the teens, 20s and 30s. I guess that's what we would expect for inherited disorders like Marfan and Loeys-Dietz. You'd expect the largest number of people to need treatment probably before they were 40. And I think that's what we're seeing in the age demographic of our patients. Disease applications, we set out to address Marfan syndrome, and hey-ho, of our 359, nearly 200 are Marfan. So, you know, we are the largest group without a doubt. Interestingly, 13 cases presented with a serious mitral valve problem which required surgery. They also had mildly dilated aortas, which probably wouldn't have reached the guideline point, which would have said we need to operate. But the surgeon said, well, hey, while we're going in to repair the mitral, we'll repair the aorta as well. So they had a mitral valve repair. They had a PEARS put on their aorta. They'll probably never have to go back to hospital. They certainly won't need another operation in a few years when their aortas dilate, which is a very, a big win for both the surgeon and the patient and the healthcare systems. We've done a fair number of Loeys-Dietz patients. As I say, they've got an even more fragile aortic wall than the people like me with Marfan. So this is actually a great repair option for them because it doesn't involve suturing into their fragile tissues. We've done a lot of bicuspid aortic valve cases, slightly different aortopathy. Very often they've actually got quite small valves, but they're very, very big in the ascending aorta, where Marfan and Loeys-Dietz tend to be big at the valve and then a little bit smaller in the ascending aorta. We've done a lot of idiopathics as well. These are a variety of different disease types and genetic conditions. They're not quite as lucky as us in the sense that many of these conditions are not inherited. So it's not as though you can pick up one person in the family and then monitor all the others, you know, which is how I suspect many of you who've been identified. These people are going to kind of present, and if you're lucky enough, you'll get them early enough to repair them. We've done quite a few actors as well, actor 2 cases. That's another genetic mutation which leads to this problem. These other headings I've got down here are just there to make the numbers balance for you, but they're too complicated to go into here. They're not really what we're interested in. Okay, so the options for those of us with a dilated aorta, the essential options, and I apologize for not having the Florida sleeve on here, though I don't think that too many people actually get access to the Florida sleeve. The options essentially are these. As I say, when I was first talked through the surgery, I was only offered a total root replacement, which was not particularly attractive. I've got to say that when I compare valve sparing with total root, I think that would be quite a difficult decision to make, because whilst valve sparing root replacement means you don't end up having to take the anticoag, you avoid the anticoagulation, the reoperation rate, it might look quite small there, but it's actually quite large. If you're a 20-year-old and you want to live till you're 70, you want 50 good years. If you have a valve sparing root replacement and you're subject to this statistic, because of course not all surgeons are the same, if we could all ring up Tyrone David or Duke Cameron or the next best guy, you'd be fine. I know people whom John Pepper has done a valve sparing root replacement for, and they've never gone back. But if we're subject to that statistic, because we get the average surgeon, that's quite a threat. 1.3% per annum. As I look at this table in its totality now, for me it's a complete no-brainer. I've got a short operation if I have PEARS. I don't need cardiopulmonary bypass. That's good. That's going to make me feel better. I don't need any body cooling. There's no drug requirement. And in terms of reoperation rate, the reoperation rate on PEARS is extremely low. I think we've done 3 or maybe 4 reoperations, but they were all on cases where the device was incorrectly fitted in the first place. A reoperation really, I think, is where a successful operation is done and then some unforeseen problem arises in the future. Well, all of those 4 cases, it was understood that the device had not been fitted properly, so they were going to have to be reoperations on those. The other nice thing about PEARS, I guess, is that you've got a great fallback. You can fall back into either of the 2 root replacement options. Incidentally, we've had 1 perioperative mortality in 350 operations, which is about a 0.3% mortality, which compares very, very well to both forms of root replacement. I'm going to throw 1 extra bit in here. I did the PEARS presentation at St. George's in about 2008, and Professor Hugh Bentel was present and had the generosity of spirit to congratulate me and the team on what we'd achieved. That was a great moment in this project, because Hugh Bentel has made a larger contribution to improving the quality of life for all of us with Marfan than any other single person, I would argue. Okay, how are we getting on in terms of the numbers coming up? Well, I don't like to look at this. It reminds me of how old I am. The axis for me, of course, started over here in 2000 when I started the project. I was then the first patient at the Brompton. It took us about 13 years to get to our first 100. It then took us another 22 months to get to our second 100. We're well past our third 100, and the numbers are stacking up, which is great news because it means more people are getting more choice. The only thing that really drives me is patient choice. If you want a root replacement, it's there. If you want PEARS, it's there. We've now got 28 surgical centres in 10 countries around the world. it's quite funny to look at a slide at this. Again, I just don't want to think about the amount of work that's gone into getting all this going, all the traveling I've done, all the presentations, and all of the tough discussions and arguments, even with Duke Cameron, our session chairman. But anyway, you know, it's got to be worth it, hasn't it? I've got to do something between 9 and 5, and I'm doing something incredibly worthwhile, and patients are getting to benefit. As far as the US is concerned, we've got an FDA process underway. We reckon we're going to get approval in 2021 or 22. We've got at least 4 surgeons in the States who are saying, hey, I'm doing lots of root replacements. I'd love to be doing PEARS. When are you going to come over here? Let me know when you got FDA approval. So there are going to be all sorts of other things that we'll need getting in place and organizing. But I think it's true to say I'd be very surprised if we weren't able to offer US patients PEARS in at least 2 centers in the States, probably 3 in 2022. In the interim, Hospitals Corporation of America own a lot of hospitals in the States, but they've got about 5 or 6 in London. And their London Bridge hospital is offering PEARS to all comers. So they've done patients from Chile, Brazil, Germany, and the US. In fact, we've done 5 patients from the US. We've got about 3 in process at the moment. And at least 2 of them have got their US medical health insurance company to pay for it. So for those of you who want to jump before 2022, London Bridge is an option for you. This has been a massive team achievement. I mean, it started with me and it rapidly grew. At the risk of being criticized by those whom I don't name, I'm going to pull a couple of names out of here. Tom Treasure. Without Tom Treasure, Professor Tom Treasure, cardiothoracic surgeon, without Tom's open mind and willingness to engage, none of this would have happened. And I'd probably have a metal valve going click, 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 and I'd be taking Coumadin too. John Pepper did the first 20 plus PEARS operations at the Brompton. And I would recommend you go and watch my TED talk where I talk a little bit about that. But John had the vision, the imagination to take a huge step forward, and all credit to him. And all credit to all of these other surgeons in the various countries who are doing PEARS and giving their patients a greater choice of surgical options for aortic dilation. I've been rabbiting on far too long, haven't I? Finally, I would direct those who are interested to go and have a look at extent.com, particularly jump into the film, TV, and radio, because there are some really nice pieces done in there with various TV people, all UK based, I'm sorry to say, but there's also an awful lot of information there. Please do your research on the site as much as you can. Anything you can't find out from the site, you can just drop me an email and I'll see what I can do. Many thanks.
Well, thanks very much, Tal. I hope my microphone is on, and I think I speak for everybody here and stand in awe of this effort. It is absolutely astounding how much time and effort and thought you put into developing this approach, and gratifying to see these results. There are a couple of questions I'd like to ask, and hopefully in the course of these we'll bring out a couple of points. One is that, as you've said, this is an elective operation. This is not done for an acute dissection, for instance. Once the aorta is dissected, it needs to be replaced with conventional surgery. And I think you've made this point several times as well. And I also want to address the kind of the reluctance of some surgeons to embrace this. And again, adding to what you said, there was an experience with wrapping aneurysms from years ago that didn't work out so well. And there were just many complications from it. And many surgeons, myself included initially, thought that this was just another iteration of wrapping aneurysms. But as you point out, it's a custom designed graft. The material in the graft, the mesh, is different from what we've used before. And it was often in a different disease. It was atherosclerotic aneurysms in other parts of the body. So external reinforcement got a bad reputation years ago, but I think you have refocused our community on that approach by, again, tailoring the graft and changing the composition of it. You pointed out that the graft actually becomes incorporated into the aortic wall, which is not something one reliably saw years ago. Let me ask you too to address this issue of the leaking valve. You implied that many patients with aortic regurgitation because of the aneurysm will have improvement of the regurgitation when the aorta is reinforced and reduced. But I would hope people wouldn't come away from this talk thinking that all regurgitation in every patient could be addressed by this. Some people have abnormal valves or such badly damaged valves that they too probably need a conventional approach. And it's sometimes hard to predict that ahead of time, but lesser degrees of regurgitation I think, are often very nicely addressed by this. Could you comment on that a little bit?
Yeah. I mean, clearly, if one has some inherent disease of the leaflet, then it may well be that there is nothing to be doing with the valve. But I mean, I also suspect, and we've got a lot of evidence really, for most of the people who have a dilation of the sinuses, so the Loys-Dietz and the Marfan, less so the BAV people. For those who have sinal dilation, the fact that the leaflets are no longer able to come together properly, means that the valve will begin to regurgitate. I mean, I look at it as an engineer and as an anatomist, I guess, but as an engineer. And to me, it's obvious. If your leaflets are in great shape and the only reason your valve is leaking is because the sinuses have dilated, if we then bring the sinuses back together, we can recover the coaptation of the valves and we can make the valve work properly again. And we had one case for various reasons who actually had significant dilation of the aortoventricular junction, the bottom of the sinuses, and his aortic regurgitation went up to severe. I mean, he was in a very bad place. We then brought him back down to the diameter of his aortoventricular junction at a point about 4 years earlier, where he had had a scan, thank God, but had had normal valve function, and we recovered. His valve function is now trivial to mild. So if the leaflets are healthy and the only reason the valve is regurgitating is because the anatomy around the leaflets is stretched out, if we bring it back in, we will recover the valve function. So you're absolutely right. There will be patients who have valvular or leaflet disease for whom this will not be a solution. But I suspect that a significant number of those of us with aortic dilation, which is why we're presenting, will have healthy leaflets, and it may well be that we can recover the regurg. As I say, we weren't expecting to do this when we set out. All we wanted to do was stabilize the aorta. But the fact that once we've got the shape in CAD, we can scale to any size we like. It means if we look at an aorta and we think, well, that's a little bit big, let's do a 90 or an 85%. And we've done this in one or two extreme cases. If we bring everything back in, if the leaflets are fine, but they're just not reaching each other because of the large dilation, we can recover valve regurg. But as you say, it's limited to dilation-induced regurgitation only. Any leaflet degeneration, any leaflet disease, we can't help with.
Right. Thanks for clarifying that. And the last point I want to make concerns the follow-up. You've done over 350 patients now with one death, which is really a remarkable testament to the safety of this procedure when it's done by the right people under the right circumstances. And and I congratulate you that you rolled this out in a very careful way. You didn't just start selling grafts. You had a program where surgeons had to be proctored by your senior experienced surgeons. You watched and followed the patients very, very carefully. And the follow-up data you have is very, very encouraging. But I do want to point out that often the final verdict on these operations comes from having a 10 or 15, sometimes even 20-year experience. And I think the majority of your patients still have probably less than 10 and in many cases less than 5-year follow-up. So although it's really encouraging, I think to win over a lot of skeptical cardiac surgeons, we're going to need to see a lot more patients with 10-year follow-up and 15-year follow-up. We have 20-year data on valve-sparing operations, not in large numbers, but we have some, and I think we have a better handle on the long-term results of valve-sparing surgery than this approach. So I think with time, I think perhaps the argument will be even stronger that this is a very, very attractive approach. Some people are already convinced. Some people will need a little bit more follow-up data. But again,
it's an interesting chicken and egg situation, though, isn't it? Without somebody like me jumping and being the first and pushing it, you're never going to get anywhere. Making the argument there's not enough data, that can be aimed at anything that's new. I mean, did anybody say to Hugh Benthall after he did the first total root replacement operation in 1968, oh, well, you've only got N equals 1? Well, I'm not sure they did. I wasn't around, actually. But, you know, you've got to try. And sometimes when you try, you're going to fail. And sometimes when you try, you're going to succeed. I note we have 22 patients with greater than 10 years follow-up. We've got 54 with greater than 5 years. But I think the average is about 3.5 years.
Right.
But, you know, I look at myself, you know, I'm 16 years post-op. Everything is exactly where it ought to be. And to make the argument that it's where it ought to be because of the process you have gone through, I think is pretty straightforward. One has to extrapolate, and one has to study and examine and analyze. When I look at PEARS now, it's entirely implausible for me, given my knowledge of this, that a correctly fitted device that is incorporated into an adventitia, the outside of an aorta, can fail. I entirely agree that I may be wrong. I entirely agree that there is a finite probability that that may be the case. But, you know, when we're having this conversation in 10 years, when I'm a really old man, they'll all be saying, oh, well, yeah, so you know, you've done 1,000 patients and they're all fine. But we're not going to know until we've done it. We've got to wait until we've got the experience to tell. But I think all the indications are this device, when correctly fitted, it just ain't going anywhere. So it's not going to be absorbed by the body. It will sit there. It will remain. You know, I will carry on going to the Brompton every year. I'll carry on being MR scanned, and nothing is going to change. If we were going to have seen a change, we would have seen a change in me in 16 years. We haven't seen a change. So the plausibility that my aorta is entirely stable, I think, is high. The probability that we have overlooked something, I think, is quite small. We had a really, really good team working on this. You know, we spent 4 years in the planning. Tom Treasure's a smart guy. He's been around. He's seen a lot of things. John Pepper, the same. Bob Anderson, the same. So it remains to be seen. You may well be right, Duke. I don't think you will be, but we will have to wait and see, won't we?
Yes, and I think that you nailed all of those important points. But unfortunately, the history of medicine and surgery has a lot of events where new therapies looked good for 5 years and then didn't look so good at 10 and then were abandoned after they saw 15 and 20 years. So we have to keep an open mind, and the follow-up issue is not a reason to stop. It's a reason to keep pushing ahead. It's to for people who want to explore this with you know, the benefit I think being obvious from what you've said, but the price being a little less certainty of late outcomes. But if patients want to do that and are well informed and they're in the hands of responsible surgeons and people like you, all power to them.
It's quite interesting. I think the very, very slow take up, whilst it's been tough for the company and very, very frustrating for me, I think has really helped us to move slowly and carefully, to bring new surgeons on carefully. We've got a proctoring scheme. We've got a guidance for new surgeons, and we've done it very, very good. Unlike other treatments, as you suggested, we haven't rushed out and sold them to all and sundry and waited for some gung-ho surgeon to jump in and cause a disaster. We've done it very, very carefully. We've got a good system in place, and all credit to the surgeons involved: Tom Treasure, John Pepper, Mario Petru, Connell Austin. These are the guys who've helped plan and proctor and make this grow slowly. And I think that whilst it has been a long, slow drag, I think the work and the care that has gone into the beginning is going to prove an extremely good investment in the long term.
I think that's already clear. And I'm glad you emphasized too that this is a technically challenging operation. I flew over to London to watch Colonel Austin do one of these, and I was very impressed that this requires a level of expertise and gentleness in the operating room. It is.
I mean, I've watched, I don't know, I've probably watched a dozen PEARS operations, and I'm not a surgeon clearly, but I'm still amazed to dissect out the ascending aorta is relatively straightforward. To dissect out the front of the valve around the right coronary, yeah, it's okay, it's good. But to dissect out around the left coronary artery, which is normally posterior to your view of the aorta, you can't see it. You can see, actually, interestingly, the model that we provide, the physical model that the implant is on, of course, is a three-dimensional map. It's a model of the aorta. So the surgeons very often pick up the former and say, look at the back. Oh, that's where the left coronary artery is. Yep. But to do that dissection around the left coronary artery, knowing that if you make a mistake and injure the left stem, you are in a lot of trouble very quickly. You know, you've got to have huge patience and care and confidence. You know, it really is, it seems to me almost to be an impossible task. Clearly it's not, but it's going to be a minority of surgeons that have the patience and the care and the skill to do this. And we were very fortunate in having John Pepper as our first surgeon, because many other PEARS surgeons still say, you know, this is a very difficult operation. You've got to be effectively proctored. And I'm pleased to say that some surgeons being proctored can do it after 2 or 3, and the proctor says, okay, away you go. Others say, I want to be proctored for at least 10 cases because this is bloody difficult. Yeah, they're coming on and we're getting there. But, you know, all credit to John Pepper. John had actually done a similar trick to this going down to the AVJ in his earlier part of his career. But, you know, all credit to the man to take this on and do it, to do the first 20 unproctored is an incredible achievement. A truly incredible achievement, but it's doable, and we've got the system in place, and we're rolling it out carefully, slowly, selected surgeons, and I think the clinical results speak for themselves.
Joe, we should take some questions. Do we have a few minutes?
Yes, I hope that you won't mind staying on a little bit longer because we have plenty of questions that came in. So if we can go through them, I'll bring them up on the screen. Can everybody see those? Okay, so this individual is asking whether the foundation can facilitate a more enlightened attitude here towards PEARS, as it would truly empower future patients at an extremely stressful time in their lives. And, you know, I think, Duke, you had talked about, you know, what the practice has been here in the U.S. and how, you know, in the U.S. there's a stress for long-term data and, you know, 5-year data. And right now there's about 50 patients with 5-year data. Obviously, TAL has had it for 16 years, so they do have some long-term data. But, you know, we are, I think, extremely excited about this because it does give patients another option. And I think, you know, TAL has also explained how, you know, it's a difficult surgery, and it will take time for for surgeons to be trained. But, you know, I do feel that we are looking forward to hearing more about this. So do either of you have any more comments? Duke, you want to go first?
Well, I'll just say that, you know, educating surgeons about new therapies is often a challenge. I give a lot of talks about aortic root surgery all across the world, and I always discuss PEARS. I always include it because I want people to know about these options. But it takes time, and the more data we have that we can share with them, the more receptive they will be to the conclusions or recommendations that we generate. So the foundation, I think, yes, it could, I'm sure we could do even more. So I don't see it as a matter of enlightenment. It's providing people choices and options and educating them. So we'll do more, but by no means have we you know, held this back. You know, if the FDA had approved this 5 years ago, there would be hundreds of patients probably that would have had PEARS procedure in the US. And we're often the last country in the world to get final approval on new therapies, drugs and devices.
Al, do you want to comment?
Yeah, I mean, in terms of the FDA application, this is business for Extent. It's up to us to make the application and to get approval and to get on with it. And you know, perhaps we've been a little bit too slow, but you know, as I said before, the fact that we develop slowly means we've got a robust, safe, secure system. So I think we're moving at a sensible pace. Probably a bit too slow for me, but we're moving at a sensible pace. And if patients want to take this up, then they can come to the UK. We've currently got 8 US patients in process coming over to the UK to have their PEARS surgery. So it's not as though you can't do it if you're in the US. But from the Marfan Foundation's point of view, it must be embarrassingly difficult to promote a treatment that's not available in the territory where you're based. So I entirely understand that the foundation wouldn't necessarily want to promote it. I guess my only plea as a patient would be that you know, informing patients is the key. If you tell them, you know, you can have total or valve sparing root replacement here. If you want to exercise the PEARS option, you got to go abroad. You know, informing patients, I think, is probably important. Simply in order to give them more choice. Because as I say, for me, that's what it's about. It's about patients having choice. And if you don't know about something, then it's difficult. I mean, I've probably communicated with close on 200 patients from all over the world, and I'm constantly quite depressed by the fact that surgeons don't know about this and don't say, oh, by the way, if you've got a lot of money or you've got a really enlightened health insurance company, you could go to London and have that. If patients are informed and they're given all the information and they're helped into making the best decision for them, I think that's all to the good, whatever that decision might be.
Okay, great. Thank you. So this question is asked by, so there was a question asked by Carly about advocating for PEARS in the US. I think we both covered that with the top question. So the third question here is, what are the key factors to qualify one for the current PEARS surgery?
I mean, that one is getting easier to answer. Essentially, if you've got an aorta which is dilated above the normal adult maximum, and it's still dilating, and it hasn't dissected or ruptured, then you're almost certainly suitable. I'm constantly bemused when I see patients discussing the genetic tests on the various Marfan Facebook pages and things. As you can see from our presentation, we've treated Acta 2, Loys Dietz, bicuspid, Marfan. The important issue, if you've got a dilated aorta, is that you get your aorta looked at and looked after. The genetics will make very little difference to you. It's great to have the genetics, and it's great that in 25 or 50 years' time, when we really understand how the genotype turns into the phenotype, we may be able to do things that will preclude the need for surgery even, but that's a long way off. If you're looking now, because you've got a dilated aorta now, I wouldn't be too worried about what the genetics are. I wouldn't get hung up on that. I'd get hung up on saying, what's likely to kill me? My dilating aorta. Let's go and get it sorted out, whatever way it gets sorted out.
Tal, the only point I would add to that is that although I agree that getting too hung up on the genetics can be a distraction, the threshold for surgery does depend somewhat on
Oh yeah,
genetics.
yeah.
And there are certain
Yeah.
very, very aggressive aortopathies where
Yeah.
we would operate at a smaller diameter. So
Yeah.
That's where I think genetics helps. It doesn't answer all of the questions, but the timing of surgery and the size at which the aorta really should be replaced is still something where genetics can help us a little bit.
Sure.
And that's often the biggest question is when to do this. Even if one is sure that a PEARS approach is what the patient wants and that it's good therapy, the timing of it is still unclear. And some people have pointed out that in your series, you do tend to operate when the aorta is much smaller.
Well, as I say, we've done 1/6 centimeters at a BAV case. Interestingly, when I was doing the research right at the start of this project, I remember coming across a patient who had dissected at 3.5 centimeters and another patient who hadn't yet dissected at 7.5 centimeters. So clearly there are a lot of unknowns in how the genotype expresses itself as the phenotype, what is going on with the aorta. So given the great results we're getting, I would argue that as soon as an aorta is just above the normal adult maximum, yet it's still dilating, yet is otherwise fully functional, that would be the time to intervene with PEARS. Clearly, that wouldn't be the time to intervene with a root replacement. But I mean, I think that they're different. That their root replacement and PEARS are entirely different in respect of when in the disease development do you apply them. Root replacement is last chance. You know, it's a last chance saloon. I've got to do something. My valve is leaking. I've got to get on with it. PEARS can and should be done, I think, rather earlier on.
Mm-hmm. Mm-hmm. Okay, great. This question is asked by Tina, and I think we've really gone over this in some of our commentary here. It's, will PEARS likely become the go-to standard for elective surgery in patients who are at risk for aortic dissection? And I think we still, have to see that. Obviously, it's not approved yet in the US. And I guess it's not done like in all centers, even in England or in Europe. And so I think it's going to take time and data in order to, determine whether, is it goes to standard. And it also depends on a person's personal issues. So I think it's something that we always have to say, that each patient has specific issues that have to be considered whenever going for surgery. Is there anything you want to add to that comment, Duke or Tal?
I would say, as I said before, the issue is one of choice. When a particular patient presents with a particular disease type, with a particular aorta at a particular size, dilating at a particular pace, it's for that patient and their physician to decide what would be the best course of action. And it may be it's a root replacement, it may be it's PEARS. But I mean, that's really that's a clinical decision made on a patient by patient basis. It's not some generic, overlaid generalization. I think generalizations are probably not very helpful in this sort of context.
Okay, thank you. So this one is asked by Cliff, and he wants to know, what has been the long-term outcome of further dilatation or aneurysm distal to PEARS?
I'm not actually privy to the ongoing clinical management of PEARS patients, so I don't know the answer to that. I think if there had been any problems, I would know, because I think the surgeon involved, cardiologist involved, would have let us know. But I don't. To date, I'm not aware of any. Certainly my descending aorta, my distal arch and descending aorta remain completely stable, and I think I would have heard had there been a problem. I suppose what I would say is that given that we're protecting slightly more of the ascending aorta than a root replacement, And given that our device incorporates into the existing tissues, I would say if I were pushed that with a PEARS, you would be less likely to dilate distally to the graft than probably would be the case had you had a root replacement. But it's a hypothesis. I don't have any data to support it.
There are actually two questions here, and that is whether the aorta beyond the PEARS graft dilates more or less than the aorta distal to a conventional Dacron graft, but also whether the incidence of dissection in the descending aorta is different. And from the data I've seen, it does seem it may be less with PEARS than with conventional root surgery. But that's one of the things that would deserve study, because it's not clear why it should be different in those two groups.
Yeah. Well, I mean, if you ask me as an engineer to comment on that, I would say maintaining the natural shape and the natural hemodynamics, albeit slightly altered by the dilation, probably is more easily managed and tolerated by the body than removing the aorta and putting in an artificial man-made valve and an artificial graft. But again, you know, these are hypotheses. I'm giving you a best guess, no more than that.
But it is an artificial graft, and I know years ago there was talk that perhaps it had some elasticity or resilience that that Dacron grafts don't have. But I'd love to hear whether there have been studies done on whether these grafts actually have some properties more like aorta than Dacron. In other words, are they elastic after they've been in for several years and there's a lot of fibrosis?
I think the basic answer to that is yes. If you look at the structure of a woven Dacron root replacement graft, its hoop strength, that is how much it dilates as you increase pressure inside it, within the context of blood pressures, is very, very high. So even though it'll bend, in terms of being that pressure accumulator, dilating as the ventricle contracts and then relaxing back, a composite aortic root graft or a root replacement graft is effectively a rigid pipe in terms of hoop strength. The PEARS graft has got to be more flexible, but I don't think it has a sufficiently increased flexibility that you would see the movement which you would see in a normal aorta.
Right.
So whilst I would love to claim that it was more flexible than a root replacement graft, I don't think in practice it is, particularly not when it's scarred in.
Right.
But all of the shape, the internal shape, all remains the same. So the anatomy and the hemodynamics have got to be much closer to normal and natural with PEARS than they would be with a root replacement graft.
Okay. So this next question is by Sharon, and she has a 12-year-old daughter that has a 4.1 centimeter after 2 rapid increases in her aorta. And she just wants to know, would she be too young or not suitable for this aortic size?
Well, we've done a 3-year-old who had an adult-sized aorta. That's an adult-sized aorta, but I mean, I'm not a physician. I don't have all the information surrounding this case, but if she wants to get in touch with one of our surgeons, it seems to me quite likely that that her daughter would be eligible to have PEARS surgery.
Yeah, I think the real question is, does she need any operation at all right now, and what's her disease, what's the trajectory of her aortic dilatation? But I agree that if you believe PEARS is good therapy, then there's no reason why she couldn't have it at this age.
Right. Okay. So what are the risks of PEARS compared to Bentall? Is it known that the durability of a PEARS repair is compared, and what is known about the durability of a PEARS repair compared to conventional aortic repair? And how much data has been compiled on PEARS so far? And how has it been compiled? So that's a lot of questions in there. I think we've gone through many of those. Any further comments on those?
The only comment I would make is that flippantly throwing out the randomized controlled trial question is a little bit silly. I believe, as we all know, total root and valve sparing root have not been subjected to randomized controlled trial, neither has PEARS. I think what people perhaps don't appreciate that is if you look at comparing drugs in an RCT, it's relatively easy. If you start looking at surgeries and you start looking at rare conditions and you start thinking about how you would frame the PICO for a randomized controlled trial, you begin to realize it is so problematical and the statistical power is going to be so low that it's actually probably not worth doing. And that's probably why total root replacement and valve sparing root replacement has not been subjected to a randomized trial. From my perspective as a patient, I would say, is it safe? Is it efficacious? And my take as a patient looking at the PEARS data would be, well, they've done 360 patients. They got over 1,000 patient years. They've had one perioperative death. They've had no other deaths. They've had no other dissections or dilations. That sounds pretty good. And then I go and I'd look at the stats for total root replacement and valve sparing root replacement, and then try and make some sort of comparison. For those of you interested, if you go onto the Extent site and onto the film, TV, and radio session, I interviewed patient number 100, Brent, actually, and he's a sort of numbers analyst for a bank, and he went away and went through that process and came away saying, you know what, this PEARS thing looks pretty good. So go and watch that video. That'll perhaps give you a little bit more information.
Okay, great. So we go down to the next one. Is there any development of this technique for ascending arch or other preemptive repair?
Yes, in fact, one of our patients from the US was the first person to have 2 PEARS implants fitted. The first one went from his aortoventricular junction up around his valve and up to his brachiocephalic artery. And the second one went around his arch from the brachiocephalic artery pretty much round to the top of his descending aorta. And he's a regular contributor to the Marfan Foundation Facebook page. And he's enjoying a stable aorta, aortic arch, and a drug-free life. But he's only N equals 1. He's only one patient.
He's only one patient.
Yeah.
I think this is potentially one of the more exciting applications for the PEARS technology. That is, patients who need their root replaced or part of the ascending aorta, regardless of which operation they get, valve sparing, Bentall, or PEARS, but their arch is a little bit dilated, but maybe not quite at the point where one would also include an arch replacement at that surgery. And an arch replacement does increase risk significantly. And if it were possible to wrap the arch or reinforce it with this type of material, it wouldn't be the same graft exactly, it would have a different shape and all. That might have some role. So in many other situations where you're operating because of one other problem, but you see another problem on the horizon that might be avoided or stalled by applying the PEARS principle to that part of the aorta. I see great potential there.
Great, great. So this question is asked by John. How common is PEARS been used in the UK by percentage?
The way that UK surgical stats are quoted makes it very, very difficult to tease out root replacement from various other forms of cardiac surgery. We've spent quite a bit of time looking at the numbers and the stats, and our best guess, best estimate really, is we're doing about 20 to 25% of UK dilated aortic cases. So only about 20 to 25, but that's because we're only in a relatively small number of centers, and many surgeons are reluctant to change from root replacement to PEARS.
Okay. This question is asked by Bonnie, and it has been answered by some of the presentation. As is PEARS procedure recommended for someone who has a bicuspid valve as well, and it has been done on several bicuspid patients, correct?
Yeah.
And Ray was annoyed that we didn't talk about PEARS in different sessions, but because we have the 2 people here that really know about the history of PEARS. It's more appropriate to get all of these questions answered here. And this one is asked by James. Is the PEARS structure rigid, or does it have some compliance?
Well, it has a lot of compliance in bend because, of course, the heart moves around inside the pericardium and inside the chest. So it has a lot of flexibility in bend, but it has quite a high hoop strength. So even though it's happy to flex and bend, it won't, when the blood pressure goes high, when the ventricle contracts, dilate out. So its hoop strength is relatively high, but its bend strength is relatively compliant.
Where are the U.S. centers waiting to do PEARS after FDA approval?
Can't answer that because I haven't done my homework.
Okay.
There's certainly a couple of there's certainly a hospital in Oregon.
Mm-hmm.
There are other hospitals, I just don't remember where they are, but I suspect that once we've got FDA, that we'll find that a number of people will put their heads above the parapet, and there will be a number of centers, but I just couldn't tell you right now what they would be.
Yes, I can tell you that there are many centers waiting to offer this this type of treatment. I'm not sure how the numbers 2 or 3 came about. I think that's probably hearsay, but there are many more. We need to find out with more experience and with more numbers if this is as durable and efficacious and as safe as it appears to be at this stage.
Right. And again, after a lot of training for those surgeons, because it is a difficult surgery. So the next question is, how does someone not residing in the US or UK go about seeking consultation for PEARS? They are in Singapore.
Go on to the PEARS website, go to the surgical centers, find a surgical center that's near you and contact them.
This is asked by Tina. Is PEARS recommended for people with dilated aortas due to ACTA2 mutations? And you did cover in your presentation that there have been a few ACTA2 mutations.
3 ACTA2s, yeah.
So how many PEARS operations have been performed so far total throughout the world? I am interested in statistics showing survival rate and any other associated complications. I think that was pretty well covered by your presentation, but do you want to just briefly go on?
We're actually up to 360 patients completed now with 1 perioperative death. Mm-hmm. And I think 1,038 post-op patient years between us.
Mm-hmm. And no dissections in any one of the ones that have gotten? Okay. No. So yes, this event, this session is being recorded, so people can look at it live afterwards. Is there any theoretical or empirically noticed risk worth mentioning of PEARS that does not apply to valve sparing?
Not sure I really understand the question, to be honest, but I would refer people to the clinical statistics. I mean, the ultimate arbiter here is the clinical statistics. Go and look at the perioperative death rate associated with valve sparing root replacement, and go and look at the perioperative death rate associated with PEARS, and that is really what is telling you what is going on. I could probably spout for 10 minutes on it, and it wouldn't really be of any value. The real value is in the clinical statistics.
Mm-hmm. Mm-hmm. Yes.
I think the short answer to that question is no.
Mm-hmm. Okay. How well does it apply to LDS, and how can we find numbers by center and surgeon?
Well, as I say, I mean, one of our surgeons who's done about 4 Loeys-Dietz patients really does like it because he doesn't have to anastomose the distal end of a root replacement graft into the proximal end of the arch, because there is no suturing to be done into the ascending aorta. He really does like it. I think we've done 13 or 14 Loy's Dietz. Many of them have been done at Bristol in the UK. But if you go onto the PEARS website, you can certainly look at the surgical centres. I would say any of the surgeons we've got, if you're capable of doing a PEARS operation, you're capable of doing it to a Loy's Dietz as well as to a Marfan, I would argue. But you need to speak to a specific surgeon, I would suggest.
Mm-hmm. Okay. So, is it PEARS suitable for a teenage girl 12 years old who has not finished her growth spurt? And what if the aortic root is hugely asymmetrical with one lobe much enlarged versus the other two pairs still suitable? I'm not exactly sure.
So you what one big lobe and two normal sized lobes, and she's asking if PEARS is suitable. We operated on a 12-year-old lad who had he'd been born with a transposition of the great arteries. He'd had an aortic switch operation. He'd also had a septal defect repaired. So by the time he came to us, he'd had 3 heart surgeries. His right coronary sinus, his front sinus, had dilated significantly, and it was very, very large. His other 2 sinuses were the right size. So what we actually did was we generated what we call a clinically corrective device. We built a device that used the size of his 2, quotes, normal sized sinuses on all 3 sinuses. The surgeon anesthetized him, opened his pericardium, put him on cardiopulmonary bypass, took a slice out of the front, the dilated sinus, closed it up, put the device on, took all the pressure off his right coronary artery, completely solved his problems with angina, and he went away and he's fine. So it is doable, but it is a move away from an anatomically compliant device. We can do it, but it is a movement away from what I've been discussing today.
Mm-hmm, mm-hmm. And is there a certain maximum dilatation different from Marfan or LDS, which PEARS would no longer be suitable or too risky?
I'm not sure that's a question you can really safely answer. It does seem to us, from what we've seen in terms of the cases we dealt with, that a bicuspid aortic valve patient where the valve is very often normal size, but above the valve is heavily dilated. Some of those, we've seen many of those at sort of 5.5, 6 centimeters, and they seem fine because maybe the vasculature is stronger perhaps than Marfan or Loy's Dietz. But I mean, I think that's a very, very difficult question to answer, and certainly not one that I've got the knowledge base to give a sensible answer to.
I agree. It's too complex a situation. It depends on the status of the valve and so forth. But trying to do this off bypass in a 8-centimeter aorta in a child with Loy's Dietz syndrome is probably not possible. So there is probably a certain maximum dilatation and situation where it's not a good idea, but I don't think anyone knows where that line of distinction is.
Yeah, I'd agree with that. Yeah.
Right. Yeah. Okay. What's currently the minimum age at which it's being implanted for Marfan patients? And you said that somebody did a child's young as 3, correct?
Yeah. The issue is not age. The issue is the size of the anatomy. If you have an aortic root which is of adult size or slightly larger and is dilating, we can fix it. It doesn't matter what age the patient is. In fact, it's irrelevant.
Mm-hmm, mm-hmm, mm-hmm. Okay.
Well, could I add one thing? It's not even the size of the root, it's the aortic annulus, because whether you do a valve sparing, a Bentall, or a PEARS, once you do that, you've stabilized the annulus. If you've done it correctly, you've stabilized the annulus at that size. And if that size is not going to be large enough to accommodate an adult, then you might be doing the operation a bit too early.
Yeah.
It's again, these are unusual circumstances, and it's hard to answer these questions as accurately as we would like. But there are a lot of decisions, a lot of considerations that have to be weighed in deciding best operation and the best time.
Right, correct. This one is saying, being in London, I am very astonished that it was not an option given to my son who had the David's procedure in 2018. In 2019, he had his AV replaced. He was told that he will have the PEARS procedure done sometime. However, come the time, they did not do PEARS, saying it was too risky. Why? Can he have it now? Because he still has his mitral valve prolapse and bulging in his descending aorta.
We can only treat natural aortas that are already in place. If you've already had a valve sparing root replacement, there's nothing we can do for you. So this questioner hasn't really understood what PEARS is about, I think.
Mm-hmm.
I wonder if they were talking about using the PEARS principle in a different part of the aorta.
Well, possibly, yeah. Possibly.
And again, this is too complicated, I think, to try to address in this forum.
Yeah.
I agree. What is the follow-up schedule post-PEARS, please? My son is P180 and has not been seen in 15 months, and his next review is Friday, is by phone due to the coronavirus. Is he fine? But should I worry? What about your follow-up data for your study? So it seems that he had a PEARS operation and very recently.
Mm. Well, I mean, I think it depends on your take. I mean, all of the data we have to date is that patients remain completely stable. So I certainly wouldn't be worried about it. I might be saying to my local hospital, it's time you put my son in your MR scanner and we confirm that his aorta hasn't changed size or shape. But I mean, personally, I wouldn't be worried about it. I'd say I've been traipsing up to the Brompton for the last 16 years and I'm sick to death of the inside of MR scanners because nothing ever changes. But it is smart to collect data. It is smart to monitor patients, and they should be doing it.
Mm-hmm, mm-hmm. Okay, and so I think this question by Jason has also been answered, that we don't have PEARS. Well, you do have for the aortic arch, right? Did you say you had one?
Yeah, we have done it for the aortic arch.
For the arch, yeah. But not for the abdominal aorta.
No.
Right, okay. Can you use PEARS over a traditional valve-sparing aortic root replacement that has been done if the traditional graft fails?
No.
No. I'm a Loeys-Dietz patient and interested in PEARS procedure, but am in the United States. Where do I find more information and weigh out the travel options?
Go to the Extent website, go to the surgical centres, go to London Hospital Corporation of America, London Bridge in London, contact them and they will tell you everything you need to do.
Mm-hmm. And what is the mesh support made of? Is it all synthetic? And is there a possibility of developing an allergic reaction to the material used?
The basic polymer is polyethylene terephthalate, polyester. Polyester is used for conventional root replacement graft. It's also the suture material of choice. So it is in millions and millions and millions of people. So I think any potential problems with it are probably theoretical only.
Mm-hmm. So can PEARS and TAVR be used together if a valve is floppy or bicuspid?
I don't think I would like to even try and answer that.
Yes.
That's a question. That's a question for a specific surgeon and or for you and your specific surgeon.
Yeah. At what size is PEARS recommended for LDS?
It entirely depends on family background, what size you've seen dissections or ruptures in your family. It's how long is a piece of string? I would say smaller rather than larger because many Loeys-Dietz people have difficulty at relatively lower aortic root sizes than Marfan patients, but that again is a question for a specific family and their specific cardiologist stroke surgeon.
Mm-hmm, mm-hmm. And I think you had in your presentation which countries are actually doing PEARS. They're asking about the future, but I think as more surgeons are trained in different areas, that you will see it, you know, in many different parts of the country. And when it gets approved here in the U.S., you may also see it here. So that's.
Yeah.
Are PEARS grafts made by 3D printers? Can they be made?
I think that was obvious from the presentation.
Yes.
The aortic former is made by a rapid prototyping technique, but the device itself is a textile mesh which is formed onto the former and takes its shape from the former. So what goes in you is not produced by rapid prototyping. The device that goes in you is formed on a rapid prototyped former.
Mm-hmm. Mm-hmm. This is an interesting question. For very young patients, their aortas are growing in tandem with the rest of their bodies. Will PEARS impede the normal growth of the aortas for very young children?
We only fit a PEARS to an adult-sized aorta. Doesn't matter what the age of the child is. If you put it on a small pediatric aorta, it will not grow anymore and the child will be in trouble when they're old. We would only fit it to an adult-sized aorta in a patient, irrespective of the age of the patient.
This one is a question for Dr. Cameron. As a surgeon, where does he feel the highest operative risk is for PEARS? Fitting around the coronaries, suturing the sleeve, etc.
Well, I'll give an answer, but I think Tal can also give an. I've never done a PEARS, but I feel like I'm very familiar with it. The biggest risk has been around the coronary dissection, although, as he points out, the only death in the series perioperatively was related to a coronary problem. So that is the area that I think carries the greatest risk, and really must be done very, very gently, very accurately.
Mm-hmm. Mm-hmm. And I think that is the last question, because I think we answered this question several times already. So I want to thank you so much, both of you, for, you know, the extra time that you spent answering these questions by all of these of our membership. I hope I found it extremely, you know, informative and comprehensive. I can't thank you enough for both of your times. I just want to end our session here with just a few more slides. So if for some reason you have other questions that weren't answered, you can submit them to the marfan.org/E3ask. We ask that you complete the survey session as I showed you before. Please visit our exhibitors in our virtual exhibit hall and connect with the community through the app. If you are active on social media, you can use the hashtag E3Summit20. And if you want to help us make more programming like this possible, please go to marfan.org/donate. And I want to just remind everybody that Aortic Disease Awareness Week is the week of September 19th through the 26th. We are looking forward to more programming and interesting programs during that time. And I want to thank you all again. This has been really fantastic, and I really welcome, you know, having this conversation about PEARS and offering it to our membership populations. So thank you, Tal. Thank you, Duke, very, very much.
My pleasure.
Thank you.
Okay, take care.